Hello, everyone. I'm Jason Tokarski.
And I'm Megan McGurman. Welcome to For the Love of Health, brought to you by ChristianaCare.
When's the last time you had a headache? Are you currently drinking coffee, listening to this podcast, hoping that caffeine is going to make the headache go away?
If we just called you out, we want to help you. We brought in two ChristianaCare neurologists for this episode to break down what your headache is trying to tell you. Please welcome to the podcast, Dr. Asad Fraz and Dr. Rami Al-Hader. Rami and Asad, thank you for being here today.
Thank you for having us.
Happy to be here.
How many different types of headaches are there? I think everyone listening has the kind that they think they get or they think they know about, but what are the actual medical definition headaches?
There may be too many to count. The most common ones that most people get is at least tension headache. We know about, I've had a tension headache. Everyone has had a tension headache. I usually say that the tension headache is the headache that I see the least in my clinic or in a doctor's office, because tension headache typically is not severe enough to warrant someone to go to the doctor's office. Something that you have at the end of the day, it's usually in kind of the forehead area, goes away, doesn't really persist, and I'm going to say for majority of the time. But the other type that we see more commonly is the migraine headache, which is, I would say that's the second common type that we see, that you hear about a lot. That type of headache tends to be the most disabling or the most commonly disabling headache. And it's hard sometimes to differentiate. The most common things people hear say is like noise sensitivity, but that's not always the case, right? Because you can have also like nausea without the light noise sensitivity, which meet the diagnostic criteria for the headache. It also has to be quite bad and lasting a specific amount of time. So these are, I would say, the most kind of headache that people tend to have. But I would say in my clinic, I almost never see the tension type headache, although it's very, very common.
As Dr. Al-Hader said that migraine and tension type headaches are the most common ones. We basically just characterize them as primary headaches, which are usually like benign headaches, not associated with any underlying disorder. But then like the headaches we see, 10 to 20% of them, they end up being secondary headaches from different causes. Some of those can be life-threatening causes. So that's how we basically keep them in two major categories.
So we'll dive a little bit deeper into symptoms in a minute, especially for those life-threatening headaches. But if someone is on their drive home from work right now listening to this podcast and they're like, man, I have a headache, are they just going to assume it's tension because it's been a long day? Do you even want patients to try to categorize their own headache?
Well, if it bothers you to the point that you think it's like less than a 4 out of 10, it's unlikely to be a migraine, although there are exceptions. If it's more like 5, 6, 7, 8, 9, 10, if you feel like light's bothering you, it doesn't have to be nausea. Like if your appetite is gone, noise is bothering you, it's one-sided, that sounds like a migraine to me. And it's lasting without taking any medicine more than 4 hours. That does usually fit the diagnostic criteria for migraines.
I would assume there are certain behavioral things that people do in their lives that can contribute to the headaches that they're receiving, how often they get them, how severe they are. What are some of those things? What are some of those things that people could be doing to try to minimize the amount of headaches that they get?
Certainly there are triggers for the headaches, and there are things which can worsen the headaches, but they don't trigger them essentially. So if someone has a history of migraine or history of chronic tension type headaches, then some of the behavioral lifestyle things which can trigger their headaches are increased screen time, lack of sleep, change in sleep cycle, like someone who's doing a night shift. Apart from this, we also see that specifically in migraine, factors like changes in temperature, changes in weather, certain foods, those can trigger those migraine headaches. Then additionally, what we see very commonly in our clinic is patients having mood symptoms like depression, anxiety. Those can trigger headaches. And then interestingly, specifically for migraine, there is a significant hormonal component. And that's the reason we see migraine most commonly in females and most commonly in premenopausal females, because there is a significant hormonal component which can trigger and cause those headaches. We don't usually just ask patients to go and just like find out their triggers, because there doesn't always have to be a trigger. And sometimes there just doesn't have to be any reason or any rhyme or reason for those headaches. Essentially, we just tell them that if they know of any trigger, try to avoid that. But it doesn't mean that they should be avoiding everything.
No, I agree. I think if any of my patients are listening, they know that I hound them a lot on mood and sleep, because I think that's a these are factors that you can modify and you can change. And sometimes patients by themselves, they can identify that, oh, when I don't sleep well, my migraines get triggered. When I have a day that I'm particularly was anxious, my mood was low, my mood was bad, it triggers my migraine. And so in a way, as a doctor, I don't want to just keep prescribing my patients medicine. I want to make sure that the other modifiable risk factors are addressed rather than just increasing medication. You want to make sure that other risk factors like their sleep, their mood are being independently addressed, which can help as well.
You guys mentioned weather. What do you do for that? You can't control the weather.
People say that barometric weather changes are the biggest trigger, and some people say just increase in temperature. I think the barometric weather changes most patients agree on. And I don't know if there are a lot of data telling us why the barometric weather changes affects our headaches, but I started getting migraines about a year ago. And if you remember, a month ago, we had like big storms, and that was probably like those couple of weeks were particularly bad for me. And then during those weeks, talking to my patients, we were collectively all in agreement that these were kind of bad weeks for us.
We talked about habits that can bring this on. We've talked about some of the things that you don't have control over, such as the weather or your age. What about things that are just built into you? Is there a genetic component to your predisposition to headaches?
Yeah, looking it up is quite challenging because you can see like there are studies that say there is genetic predisposition somewhere between 40 to 80% of the population. And it's hard to pinpoint an exact number, but at least I would say 2/3 of my patient would say, oh, my dad had migraines or my mom. Especially more specifically with migraines, I would say. The other type of headaches, they vary, but migraines has a very strong genetic predisposition.
Yeah, I agree. And I think sometimes patients just don't recognize that there's a family history because they just feel like, their family members or their parents or someone else in their family who had headaches, they just have like normal chronic headaches, tension type headaches. Headaches were not as a well-recognized entity a few years back, like in the past few decades. And now we are basically getting better at diagnosing them, identifying them. I think a lot of those patients who have family members with headaches, they were never diagnosed with any of those migraine disorder. So I think that does play a part.
Yeah, I agree. I have a lot of patients, I would say. I don't think anyone in my family had headaches or migraines, but my mom used to say a lot when we were younger. She would say, I have headaches all the time. She wanted to go lay down. She wasn't really diagnosed, but she did have migraines. So it's kind of sometimes I diagnose them and diagnose their family at the same visits. Yeah.
At what point do you recommend to your patients bypass me altogether and go to the ER? Or what point does someone who's just having casual headaches come see you? There seems to be such a wide range here. Where are those kind of markers for that medical attention?
If someone is having very regular, frequent headaches or headaches which basically affect their quality of life, I would say that will be the point where they should seek medical care. Either go to their primary care doctor. If they already have a neurologist established, go to the neurologist. But most of people, when they start having headaches, they just tend to ignore them. And I always tell the patients that I just don't like when people suffer in silence because of these headaches. They just tend to ignore them. They keep using over-the-counter pain medications, but that's not a permanent fix. And then the other side of the spectrum is those patients in which we suspect headaches from underlying serious causes. And those are the patients who should go to emergency, and we usually recommend them, if they call our office, to directly go to the ER. There is a mnemonic we use. We have certain conditions which can cause such headaches, which make us worry about our patients. And that includes systemic illnesses, like if patients are having any weight loss, fatigue, night sweats, and any other symptoms which are concerning. Then comes patients who have developed any neurological symptoms, including stroke-like symptoms, and if they have any abnormal eye examination. Age is one of the other risk factors. Most of the primary headache types, which Dr. Al-Hader mentioned, like migraine and chronic tension type headache, they rarely start later in the age, after the age of 50 years. But whenever a patient above the age of 50 essentially has a new onset headache, we always make sure that there's no secondary component to it. Moving forward, along with the older age, the onset of headache also is something which can be very important, especially if a headache starts suddenly and goes to severe intensity, 10 out of 10 intensity within a minute or so, within a few seconds, it's usually called as thunderclap headache. That can also be sometimes from very serious underlying causes. And then there are a few other things, including headaches which are significantly getting worse over the few days to weeks, headaches which are worse in specific position, headaches which basically are a part of increased pressure in the head, which get worse, and headaches which are part of low pressure in the head, which get worse on standing up. Amongst these, we always want to make sure that whenever we are suspecting any of these causes, we always send them to the ER, or at least, if not to the ER, we at least order some lab work and diagnostic workup to make sure we're not missing anything.
Yeah, I agree. And I think the other thing to note, if a patient of mine have been having migraines or, they've had them for many years, the one thing I always tell them is make sure that if your headache suddenly changes and it's quite severe, that is a reason to go to the emergency department, because there has been a sudden change. And if it's the same type of headache that has changed, that is a little bit worse, that's okay. But if it's a new type of headache you've never had and you're having any neurologic symptoms, numbness, weakness, that's the reason to go to the emergency department.
One thing which I forgot to mention, and actually we end up seeing these patients very frequently, are patients who have new onset headaches in pregnancy. I think that's one of those cases where we get very worried and we want to make sure that there is no abnormal blood vessel issue or any blood clot in the brain. So anyone who is pregnant and having new onset headaches, that is basically a red flag.
If one of your patients is listening to this, who may be one of your patients who is really on the lighter scale of, the tension headache, just the day-to-day, maybe it's hormonal or something that is a little less severe, what are those easy takeaways you give them of, hey, if it's 2:00 and you're in a work meeting with a headache, try XYZ?
I mean, we usually start with over-the-counter, like Tylenol, ibuprofen. But I think the issue sometimes we run in is, unfortunately, with Tylenol, ibuprofen, sometimes it doesn't say on the bottle how frequently you should take it. And sometimes when you take Tylenol and Motrin over-the-counter so much that you run into rebound headaches. So the first step, I say try over-the-counter. We don't have to do a prescription. Second step, there are some supplements that can help, magnesium, vitamin B2. So it doesn't have to be prescription medication, since some people say, I don't want to do anything prescription. So this is where I usually start off, but it depends also how much it's affecting the patient's life, how much they say their headaches.
What about hydration?
Yes, that's one of the most important points which we talk with our patients, especially when we're counseling them regarding headache and good headache hygiene. Hydration status, especially dehydration, can actually significantly worsen headaches or trigger headaches in many patients. While talking about hydration, I do think it's important to mention about caffeine use as well, because a lot of those patients who come to us, either they're drinking too much caffeine, so they're having caffeine overuse headaches, or they drink caffeine and they just suddenly stop drinking it, and so they end up getting caffeine withdrawal headaches. I always ask patients about this, and additionally, I always ask them about energy drinks, and because a lot of those energy drinks if used frequently, can also trigger headaches.
I can tell myself that when I'm dehydrated, I have a worse headache than usual.
Yeah.
But caffeine is funny, because caffeine can be used to treat headaches, because if you look at some of the over-the-counter medicine, they have caffeine, and some patients would tell you, when I drink a cup of coffee, it helps my headache. But it's you need to have a balance between not using too much caffeine and, using it as indicated or as useful, at least.
You mentioned those kind of family stories of grandma would have a headache. She'd just go lay down and nobody ever really knew what it was, or that kind of thing. Now we have a little better idea. What are some of those other myths or anecdotes about headaches that it would be good to dispel?
I would say the most common one, I would say, it's probably sinus headaches. Sinus headaches do exist. So in the case of someone having an acute sinusitis, meaning an acute sinus infection that needs antibiotic, you will have pressure in the front part of your face and needs antibiotics and treatment and all of that. But mostly, maybe 90-95% of the time, chronic sinus headache, it's most likely of a neurologic condition rather than an ENT or a sinus condition. And which unfortunately sometimes it leads to unnecessary surgeries, people going to the wrong provider. So I usually tell my patients or anyone, if you think you have sinus headache, it's a good opinion to talk to a neurologist first. And if they do their workup and nothing comes up, it's okay to talk to an ENT, see if that is the second choice. But starting off with sinus headache and calling it sinus headache is a little bit I think it's a myth one way or another. I don't know if that's how you agree. Yeah.
I agree. One thing which I would like to mention here is that when we think about headaches, we think about head pain, but we forget that facial pain can be a very common part of headache as well, especially because of the way the nerves are supplying different parts of the face and the head, and it's the same nerve which supplies both regions. You can have a lot of times pain involving parts of the face, and as Dr. Al-Hader said, that patients end up having surgeries. We have seen patients who had surgeries for dental procedures, like teeth pulled out, because they thought the headaches were coming from their tooth. But it ends up being one of those headache disorders which we commonly see. And one thing which I think we would both agree on is that we are seeing a lot cases of medication overuse headache, as Dr. Al-Hader mentioned. Patients think that they can just keep taking over-the-counter pain medications as much as they want, as long as it's within that required limit. They can take it every day. But what ends up happening is that just ends up lowering their pain threshold, and they end up getting more headaches. We call them as medication overuse headaches or rebound headaches. I think that's one of the very most important things which people need to know in general.
Yeah. And the last one, I would say maybe not every patient needs a CAT scan or an MRI to get diagnosed with a migraine or headache. Sometimes just sitting down with your doctor is good enough to make a diagnosis. And some patients do end up needing to get an MRI or a CAT scan, but I would say not everyone needs a scan to get the diagnosis.
Yeah. And one of the other things which I think is important to mention is patients think that once they get a diagnosis of migraine, they're going to just suffer throughout their life. And yes, it's possible that they might end up having migraine throughout their whole life, but we see a lot of patients in which they have migraine, and then with age and with changes in hormones, especially in females, their migraines go away. And sometimes if they go away, they think that they're not going to come back. But then we see patients who are elderly and they come to us and they say, I used to have headaches in like my 20s, 30s, they went away. I don't know why they're back. So in those cases, we do make sure that we are not missing anything serious, but it still can very well be a migraine headache.
I do hope I can grow out of my migraines at least.
I hope so too.
Thank you both so much for being on the podcast today. I hope it was educational for all of our viewers.
Sounds good. Okay. Thank you for having us.
Thank you for having us.
Thank you.
Check out the show notes for this episode to wrap your head around more information on headache and migraine treatment at ChristianaCare.
And you can always keep up with For the Love of Health on social media. Just search ChristianaCare on your favorite platform.
We'll be back in 2 weeks with another great conversation.
Until then, thanks for joining us for the Love of Health.